and I'll mine is second.
Just get some money.
And I'll mine is second.
Just get some money.
Sir, Raju sir.
And I'll mine is second.
Just get some money.
Sir, Raju sir.
And I'll mine is second.
Just get some money.
Sir, Raju sir.
And I'll mine is second.
Just get some money.
Sir, Raju sir. Raju sir.
Yes, sir.
I have shared your table start.
And I'll mine is second.
Just get some money.
Sir, Raju sir. Raju sir.
Yes, sir.
I have shared your table start.
And I'll mine is second.
Just get some money.
Sir, Raju sir. Raju sir.
Yes, sir.
I have shared your table start.
And I'll mine is second.
Just get some money.
Sir, Raju sir. Raju sir.
Yes, sir.
I have shared your table start. Sir, why?
शेयर हो रहा है सर?
सर हो रहा है, दिख रहा है. सर
Okay, okay, ठीक है. I'll minimize it till then, yeah? Or shall we stop
सर हो
it?
रहा है, दिख रहा है. Yes sir.
Okay. Stop share, yeah?
No. You can have
minimize it
because
till then, yeah?
after starting
Or
the
shall we stop
introduction, first speech will be your only.
Okay. Stop share, yeah? Okay, ठीक है. Yeah.
No. You can have
minimize it
because
till then, yeah?
after starting the introduction, first speech will be your only.
Stop share, yeah? Okay, ठीक है.
No.
Raju and Shishir ಅವರೇ,
After starting
ಹೇಳಿ
the
ಹೇಳಿ
introduction,
ರಾಜೇಂದ್ರ.
first speech will be your only.
just I think better we'll start ಇನ್ನೊಂದು 2 minutes ಅಲ್ಲಿ.
Yeah, I think we're already 8 minutes late.
10 minutes then. I think better we'll start. So the plan is that just I'll give the brief introduction.
Yeah, I think we're
Introduction, just a quick welcome speech.
Yeah.
15-20 seconds. Then Mahesh sir will take over and he'll give the introduction regarding the speakers. 15-20 seconds. Then Mahesh sir will take over and he'll give the introduction. And afterwards, principal will take over for speakers. 15-20 seconds.
Fine,
Then
fine, yeah.
Mahesh
No
sir will
problem.
take over and he'll give the introduction. And afterwards,
Before I am giving the introduction, Dr. Vaishali Mohitti will speak.
No
Few
problem.
words.
Yeah. Then Rajendra will hand over to Vaishali
Before I
madam.
am giving the introduction, Dr. Vaishali Mohitti will speak.
Sorry?
Few words.
Yeah. Then Rajendra will hand over to Vaishali madam, I
Before I am
think.
giving the
Yeah.
introduction, Dr. Vaishali Mohitti will speak.
Sorry?
Few words.
Yeah. Then Rajendra will hand over to Vaishali madam, I
Before I am
think.
giving the
Yeah.
introduction, Dr. Vaishali Mohitti will speak.
Sorry?
Few words.
Yeah. Then Rajendra will hand over to Vaishali madam, I think.
So, we'll start in 1 minute. Sorry? Okay.
Yeah, sir. Yeah, Suresh, we can hear you.
Mahesh, are you recording? Isn't it from the
Yes. Once it will be started, I will be do recording.
We can hear you.
Mahesh, are you recording? Isn't it from the?
Yes. Once it will be started, I will be do recording.
We can hear you.
Mahesh, are you recording? Isn't it from the?
Yes. Once it will be started, I will be do recording.
We can hear you.
Mahesh, are you recording? Isn't it from the?
Yes. Once it will be started, I will be do recording.
Yeah, he's recording. Yeah, he said.
Are you recording? Isn't it from the?
Yes. Once it will be started, I will be.
Yeah, Suresh, he's recording. Yes, Suresh. He said.
Are you recording? Isn't it from the?
Yes. Once it will be started, I will be.
Is it live on YouTube? Eh? Yes, Suresh. Is it live on YouTube? Eh? Yes, Suresh. Oh, is it? Okay. Maybe you can ask somebody whether they can help you. Whether oh, is it? Okay. That time either Shishir or Rajendra. They can help
We'll try from here.
whether oh, is it? Okay. That time either Shishir or Rajendra. They can help
We'll try from here.
whether oh, is it? Okay. That time either Shishir or Rajendra. They can
We'll
help
try from here. Facebook.
oh, is it? Okay. That time either Shishir or Rajendra. They can help
Try from here. Facebook. Raju,
Hey, Rajendra.
it's getting completely echo. You want like still I can hear Suresh. I can hear Mr. Suresh voice from
Hey,
here
Rajendra.
now. It's kind of echoing. You want like repeat it.
Do you know?
Still
Do you
I
know
can
why?
hear Suresh. I can hear
If
Mr. Suresh
there are
voice
2
from
or
here
3
now.
screens on one screen
No,
open.
only one screen
Do
is
you know
on.
why?
I can hear
Okay,
Suresh.
I can't hear echo now. I was hearing echo when I switched on the YouTube,
One screen is on.
but as soon as I switched off the YouTube, it's fine now. I was hearing echo when I switched on the
Nothing
YouTube,
is on my from my end.
but as soon as I switched off the YouTube, it's fine now. I was hearing echo when I switched on the
Nothing
YouTube,
is on my from my end.
but as soon as I switched off the YouTube.
Okay, shall we start then?
Hello, sir. Hello, sir.
Vaishali madam.
Good morning, sir.
Good morning. Are ready? Shall we start then?
Sir, we are using in YouTube. We can't see, sir.
Okay. And how about Facebook?
It's okay, sir.
Facebook is okay, isn't it?
Okay, sir. Thank you.
Thank you.
ಸುರೇಶ್ ತೊಂದ್ರೆ ಇದ್ರೆ ಒಂದೇ ಒಂದ್ ಮಾಡಿ ಬೇಕಾದ್ರೆ ಐದರ್ ಫೇಸ್ಬುಕ್
I
or
think better we'll go
YouTube.
with Facebook and we'll come back with the YouTube later on.
Yeah. It Facebook is better ಅನ್ಸುತ್ತೆ. Yeah.
Suresh, are you okay with Facebook?
YouTube is okay.
Yeah, that's fine. Okay, so we launch this. Ready then? Okay. Good morning to all. It's nearly afternoon in India now. Here it's 6:10 in the morning, and approximately the temperature is -4 degrees here. So this is your first webinar in 2021, and wishing you all happy and prosperous New Year. Hopefully this year will be less eventful and more peaceful. With a great respect and honor, I would like to invite all our principals, teaching faculties who are the backbone of every educational sessions conducted by Global Indian Nursing Association. It's a great pleasure to invite following dignitaries from Krishna Institute of Medical Sciences, Karad, Maharashtra, who are co-hosting today's webinar. Dr. Suresh J. Bhosle, Chancellor, Dr. Neelam Mishra, Vice Chancellor, Dr. Ved Prakash Mishra, Chief Advisor to Chancellor, and Dr. Vaishali R. Mohate, Dean of Krishna Institute of Nursing Sciences, Karad. I invite Mr. Mahesh to give the brief introduction regarding today's speakers. Thank you.
Sir, before that, Dr. Vaishali, we should invite the Dr. Vaishali.
Okay. Dr. Vaishali, madam, please can you come over and just a quick, just say a few quick words. Thank you.
Yes. Good morning, one and all. I wish you a happy new year.
Good morning.
Yeah. I'm very happy to see you all the speakers from GINA member. It's a joy and privilege for me to join you virtually, and my congratulations to all of you and entire team for giving new meaning to a collaboration and growth of organization. We prosper to grow in truly developed world, and we get an equal opportunities, equal representation, and equal access for the thinking. So I thank you all the GINA members, proactive members, Mr. Raju Maitri, Mr. Rajendra and Mr. Shishir Kore, today's eminent speakers from the nursing profession. I thank my on our Honorable Dr. Suresh Bhosle, Chancellor of Krishna University, Karad, for his path-breaking work and uploading his vision and commitment in health sciences. I'm very much delighted to be a part of team for the today's meeting and collaboration with the GINA. United Kingdom and Krishna collaboration with our university, Krishna Institute of Medical Sciences, deemed to be university. And this brief about few seconds I will take. Brief about the university. Krishna Institute of Nursing Sciences is established in 1983 by our founder chairman, late Shri Jayavant Raoji Bhosle, and under his the able guidance and visionary of our Honorable Dr. Suresh Bhosle, institution is flourished from diploma, BSc Nursing, post BSc Nursing, MSc Nursing in all high specialities, and PhD Nursing and Nurse Practitioners course. That is why I'm excited to collaborate with you, as we have a potential, and it has to bring out the sustainable change, with also special for us, as we are the celebrating 37 years, and through his vision and humbled, impacted millions of lives in the country. In a ways, the healthcare delivery as a daughter, as a mother, as a teacher, I'm pleased to present our Chancellor, sir, has I respect and with the humiliation, our Chancellor, sir, has given us opportunity to write his own destiny with the power of technology, with the power of healthcare, with the power of education and joyful support. On behalf of Krishna Institute of Nursing Sciences, I promise you wholehearted support and commitment in making collaboration and resounding success. It will be long cherished, long truthful in this trying time. I wish safety and good health. And I over to Mr. Chetke for our. We are very eager to listen, Mr. Raju Mistry, today's eminent speaker. Over to you, Mr. Chetke.
Thank you, madam. As already decided that there will be the 2 sessions. So, and for that 2 sessions, there are the 2 speakers. So the first speaker, Mr. Raju Krishna Maitri, I am going to introduce initially, and after his speech, I will introduce to Mr. Shishir Kore, who is having the second session. So initially, I am going to introduce about Mr. Raju Krishna Maitri. So he is from the Belgavi, Karnataka, India, settled in the UK since 10th May 2001, almost 19 years. Senior nurse CCU and the primary PCI coordinator, NHS Trust, UK. She has a nursing graduation from the KLE's College of the Nursing, Belgaum, Karnataka, India. Work as a teaching faculty and the management areas in the various institutions. He has also worked as a medical devices training officer and the member of the NAMDET, National Association of the Medical Device Educator and the Trainer. He has worked in the primary, secondary and the tertiary centers of the NHS services, UK, experience in clinical areas like the ICU, CCU, specialist ward, community areas like the care homes and the district nursing, teaching, training many students, healthcare workers, nurses, technicians, paramedical staffs and the doctors. He is the organizing secretary of the International Nursing Conference, successfully conducted at the KLE's Institute of Nursing Science, Nehru Nagar, Belgaum, Karnataka, India in November 2018. He was a chairperson for the panel discussion in the International Level Nursing Conference. Again, he has a diploma in non-invasive ventilation, the Entry University, Liverpool, United Kingdom. Again, he has done the coronary care course, Bangalore University, North Wales, United Kingdom. He has done the advanced life support course, Resuscitation Council, United Kingdom. He has done the mentorship course, in Wrexham, North Wales, United Kingdom. Then he has completed the medicine management course, Glenclad Hospital, United Kingdom. He has the many sports, cultural, and the social, political, and the charity activities. He is a founder and the treasurer of the Sumerian Cultural Association United Kingdom 2008. He is a life member and the former treasurer and the current deputy treasurer, executive committee member of the Kannada Balga UK. Then he is a life member of the Kannadi Guru UK, member and the player of the North Wales Cricket League. Then he is a school governor, parent of the local primary school in the UK. He is a councillor. He is a member of the Deccan Mountaineer Club UK. He is a founder of the Bodybuilding Badminton Club UK. He is a life member of the TNAI British Red Cross Organization. He is a registered member of the Nursing and Midwifery Council and the Royal College of the Nursing UK. And he is also linked with the many NGOs in India and the UK. So this is not complete his introduction. Yes, it is his brief intro. And with this, I am handing over the session to Raju Metri. I welcome him in this talk. Thank you, sir.
Thank you. Good morning and good afternoon, everybody. I believe everybody can hear me. And may I request everyone to mute yourself, please, because there is a lot of disturbance while I was listening. So I'll really appreciate, and you can unmute it when it has been asked. And thank you very much to Krishna team and Vaishali, who is my good colleague, and Mahesh and Prabhu, who are the backbone of this conference, working very hard. And we are already 20 minutes late, so I'm just going to go straight away for the presentation. So today's topic, I'm going to talk about a journey of a cardiac patient. Everyone must have had a fantastic 2020 or ups and downs. And, it's like a VF or a VT in the ECG in our cardiac department. And can you all see the slides? Rajendra, if you can show me the thumbs up. Oh, thank you. So now I'm wishing you all a very safe and comfortable sinus rhythm in 2021. And so with wishing that one, I'm just going to quickly highlight about the aims and objectives of this talk. So one is first to gain the knowledge and the understanding of this journey of a cardiac patient. And it's a whole picture of the journey from the heart attack till he discharge and go home. And the second thing is care and the management of patients who suffer acute coronary syndrome. Obviously, the objectives are very quickly. Basic brief ANP of the heart rhythm and the origin. To know the journey of the patient with the cardiac problems. Call to needle time and a door to needle time. Care during the travel in the lab, CCU, cardiac ward, and a cardiac rehabilitation. I'm just getting some disturbance again. If somebody can mute it yourself, please. I think it's somebody called Santa Day. Santa Day. Thank you. And now next one is why I have chosen this. Dhanashri Rokde, can you unmute? Please? Can you mute yourself, please, Dhanashri? Dhanashri Rokde.
1 second.
Thank you.
Maya sir, can you make me host, please, here, co-host, so that whatever the disturbance.
Thank you. So why we have chosen this topic today? Because cardiovascular health related problems across the world, these are some of the key facts. CVDs are the #1 cause of the death globally, and an estimated of 17.9 million people died from CVD, which is a cardiovascular disease, in 2016. and that is representing a 31% of all the global deaths. And of that deaths, 85% are due to the heart attack and a stroke. It is a huge percentage. If you look at the percentage, then these are the figures from World Health Organization's fact sheet on the cardiovascular diseases. And this is another slide. Before I go into ANP, what causes it's a basically, it's in the red color. We are showing the communicable, maternal, neonatal, and nutritional diseases. Blue one is a non-communicable diseases, and the green one, which is a road injuries, number 8, is about just the road accidents or something. So here also, other than the diabetes, you can see the cardiovascular diseases or the ischemic heart diseases are the again, these are the biggest causes of the death, and that's why we will just keep our heart healthy. And and obviously it is 2021, and what is, everybody will start with a full of energy and excitement in 2021. What is your goal? What is your goal for 2021? We'll talk end of December, in the beginning of January. And my goal is not to become a goal in the 2021. And I think Huli sir will agree with that one. I don't want to become a goal, and sir doesn't like it. So this is our basic heart, everybody knows, and there is nothing changed in 2020 or 2021. It was same, and it has been the same. And this is the basic anatomy of the heart, which has got 4 chambers, atrias, 2 atrias on the top and 2 ventricles on the bottom, and the superior vena cava and inferior vena cava where the blood comes. And I will just go through in the next slide again. So when there is a heart, there are 2 things. One is a flow, and the second is a electricity. So there are both the things should work simultaneously to work, or the continue to beat this heartbeat for us. So again, the electricity, there are 3 important things. I want you to listen to these important things, because the conduction system, which we call, and there are, number 1, if you can see here, it is a sinoatrial node, which is a natural pacemaker of the heart. And this natural pacemaker of the heart, it is activated or when there is atrial depolarization. And that time in the electrocardiogram, when we take the graph of the heart, and that is representing here as a P wave, and that P wave represents as a sinus rhythm, or that's why it is called a natural pacemaker of the heart. And when this fires the electricity, and this sinoatrial node, which is situated in the right atrium, on the top of the right atrium, and that fires, and that pathway goes into the number 2, where we can see is atrioventricular node, AV node, and then it goes to the, and at the same time, as you can see, this is the left atrium, and the P, when it is firing the electricity, it goes to the left side of the heart as well, and then it passes to the middle of the heart, which we call as a septum, and that is called a atrioventricular bundle, and then that divides into the right bundle and the left bundles, and then those branches, and then they divide again into the bundle of His, and these are the Purkinje and His, and all these are the name of the scientists. So when there is a delay in reaching from number 1 on the top of the right atrium to the number 2, then there is no P waves at that time. Or if there is a reaching on time, then there is a continuity of the muscular activity will be there, and then the heart will continuously beat. And then when there is a depolarization of the ventricles, remember there are 2 chambers on the top, that is a depolarization of the atria, and the 2 chambers in the bottom, which is a ventricular depolarization, and that is called a QRS complex. And we'll go through in a next ECG or something. And then when there is a ventricular repolarization, when that repolarization is occurring, or the recharging, that time there is a little bit of pause, and that is when we represent it in the ECG called as a T wave here, and that is what we call it as a PQRST. And this is another animation which you can see. There is a flow of the electricity is going continuously, and in this picture you don't see any of the arteries or the coronary arteries or any blood vessels here. So just remember, this is the electricity, and the flow is a pipelines. So SA node, AV node, number 2, it comes to the fire there, and then obviously it reaches to the central of the heart, and then it passes through the bundle of his and then the branches. And then here, why it is important, I'm just talking about this one, is the coronary flow and the perfusion. If you look at this graph, in this aortic pressure and the coronary flow, because there is always a coronary flow is always higher in the diastole for the coronaries, because coronaries will get the supply of the blood when there is a resting period or the diastolic, because the whole body gets it during the systolic when there is a ejection is happening, and when there is a diastole, then these coronaries are you can see there when it's becoming a yellow color and then becoming the red, if you will be able to see this flow, then that's why when there is a ventricles are relaxing and this coronary flow will be more and during the diastole phase. So we need to remember this one. And again, this one is every day on an average, the heart beats is around 100,000 times and pumping 2,000 gallons of blood through our body. And that is a lot of work for an organ, which is just not as big as our big fist. And which is only weighs about 12 ounces. And this has to work continuously, whether you're sleeping or whether you're awake, whether it's a day or night, 24/7, all 365 days. So now we'll just quickly go into this quiz, and I hope my colleagues are able to do this one. If you can just look into the link which my colleague is going to share, and if you can answer quickly, there are I think 4 questions. If Shishir or one of our GINA member, Rajendra or Suresh, they are going to help me with this one. Is it okay, Shishir?
Yes, Rajiv. Rajiv, we're just trying to find the chat box.
Okay, that's fine. Yeah.
Give me 2 seconds. If you can't, then we'll proceed. And
That's
then we'll
fine. At the end, we can share.
Sure, sure. Is that okay?
Yeah.
Yeah.
We can't see the chat box here, just to send a message for general discussion. Mahesh sir, can you look into this one, please?
Yes.
So if you can make me a co-host as well, so that I can quickly send this link for the quiz. It's a very short quiz. Okay.
Sir, chat box is inactive.
Is it active now?
No, it is still inactive.
Okay. Rajiv, shall we continue, and then once we figure this out, we'll do it at the
Sure. Yeah, that's
maybe.
fine. Yeah, no problem. Yeah, that's fine. I'll continue with that one. Yeah, because we're already running out of the time as well. Yeah, no worries.
Right.
So
Correct.
again, sorry about that. This is about the quiz, and which is quite interesting for everybody. This is a journey of a patient. Again, around 1.4 million people alive in the UK today, because they survived a heart attack because of the services we provide here. And out of that 1.4 million, there is more than 1.4 million are men, and nearly 400,000 people or the patients are from women. So it's a huge number. If we didn't have the service, it would have been really difficult. And I live in a small place called North Wales. We got only 4 primary PCI centers. Just to tell you quickly about what is primary PCI center is when anyone has a heart attack without thrombolizing these patients, and we'll just directly bring them into the centers, specialist center, and we'll open up their arteries with the non-invasive procedure, and then that will be treated, and then they will be sent home. And that's why we in United Kingdom, that's not the latest figures. I think we got around 150 cardiac centers in the United Kingdom, and it's a huge number. If you look at the per 1 lakh people, it's a huge number of centers, because in UK there are average of 22,000 hospital admissions every week, where there is a heart or a circulatory diseases, which is like a stroke or a heart attack. And stroke is the number one, because 2,500 patients are due to stroke, and 2,000 people are due to a heart attack.
Rajiv, sorry, just can you share your screen, please? PowerPoint.
Yeah.
Oh, it's not coming.
Yeah.
No, it's not. I think
It's not
stopped.
the
It is.
I'm searching that only.
Oh, sorry. Sorry about that. Can you see it now?
No, sir.
No, not it.
Now.
I didn't touch anything because.
No, I
I
have
think
changed the presenter now.
Oh, okay. Can you see it now?
Now it is visible.
Okay, I'll make it bigger screen. I'm really sorry, I didn't know. Because I can't. Okay, so this is the previous I was talking about, the 1 million men and 380,000 women are affected, and they are survived because this heart attack, because of the services we provide. And then I'm not going to talk much about the coronavirus now, because the coronavirus started in 19, and there are a reduced number of cases coming, because less than 50% of the cardiac centers are not working actively, because the number of patients related to the cardiac or the stroke have come down drastically. But there is a relation between the coronavirus and heart problems in the long run. And when we call about the COVID, long COVID symptoms, or long COVID, we call it that condition as. And then when going to the next one, these are the most important signs of the symptoms, or the warning signs we get. And to highlight main is the first one is a chest discomfort, and that comes as a dullness or a squeezing sensation of the pain. And you can see the patients when they talk about holding it on their left hand side of the heart, unless they have got a dextrocardia. And then, are you able to see, Mesh? And then there is a jaw pain, or the toothache, or the neck pain they call. And obviously there is a short of breath, and that is a typical one of the sign the patient will show us. And then they will have a nausea or vomiting. And because the epigastric pain, or the heartburn, or the indigestions, these are all similar kind of things, and we cannot just ignore them thinking that, oh, you just take some antacid and you'll get better. Because these kind of things, patients, you need to look into their, when you look at the patient, you need to look into their thinking about how they look, how they feel, and what are their what is their background and the history and everything, and whether there any problems with the like a muscular problems, like any kind of fractures or any muscles injuries or anything, those all kind of things. So, and they also feel the dizziness or a lightheadedness or a headache, and these are the complaints the patients will always give us. And then just to give us a background, what is really recording? Just when somebody comes to you, you can't just take a blood and send the blood to the lab and wait for it, because it takes time. It is very important to do the bloods, but it is those markers are important, but it takes time. But in this scenario, the easiest and the quickest thing we can do is a electrical line, which is a ECG. And when the ECGs arrive, these are just not the PQRST, these are not just the alphabets. And that's why it's a very important when you're looking at the cardiac patients as a cardiac nurse practitioner or a primary PCI coordinator. So what are you observing in that rhythm strips? And what does the patient look like? And do you know the history? These are the three things you have to think about it. And when you're looking at the ECG, just remember, because the ECG is just a wiggly line, and it is very, very difficult to know in the beginning or understand, because when we don't know it. So these are the 6 steps approach we do. Is there any electrical activity, or what is the QRS rate, and what is this QRS, whether it's a broad or a narrow, regular or irregular. You can see it in a pattern. And if you difficult, then get a pen and a paper and just point it towards. It's difficult to explain it, and then you can just do in that way. And then whether the QRS complex is a normal or abnormal, which is you can see the whether the narrowing or it is a prolonged, which is a broad. And is there any atrial activity present, which is like a P wave? I was talking to you about the P wave. Is atrial activity is present or not? And if there is an atrial activity, you need to check whether that every QRS is followed by P waves. So then every P should have a QRS. It's like always husband and wife, husband and wife, husband and wife. So they need to go together. And if there is a disturbance in that one, then that ECG is not normal. So that's why always remember to keep it very simple. This 6-step approach is very, very helpful. I'm coming back to my thank you. Sanjay is
Yes, sir.
ಸಂಜಯ್ ಕೆಜೆ ಮ್ಯೂಟ್ ಮಾಡ್ತೀರಾ? ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡ್ತಿದ್ದಾರೆ ದಯವಿಟ್ಟು. Thank you. So these are the 3 things we look into the journey of cardiac patients. So one is a primary, second is a secondary, and the tertiary. So when the primary we talk, it is a home or the community wherever they are living. And the secondary is when they come to the hospital, which is a cardiac center in this scenarios. And then the tertiary is when we can't treat in the cardiac specialty center, we need to send them to specialty centers, where my colleague is going to talk about later on what kind of procedures and what kind of things they are going to do. My colleague Shashir is going to talk about that. So when there is a communication between the 2 areas, we always use the S-bar method. And I think S-bar is very simple because it's a constructive with everything without missing any of the information about the patient. So S-bar is situation, background, assessment, and the recommendations. So if we follow these 4 steps, and we are not going to miss any of the important informations about the patients, and we are not going to pass the details about this patient to the next team, because we have a day and night shift, we have a team changes, doctors, and we have a different ward to the another ward, and we have a different hospital to the different hospital. So in between, the most and best important communication is by using this S-bar method. And then this is the most important thing, you need to remember. This is a slide we need to remember in your mind. Then what happens to this journey? So when there is a primary area, when the patient is in the home, so what happens then? When the patient has got a heart attack or a discomfortable, then obviously patient will either, I'm only keeping the scenario or keeping the picture of United Kingdom, not to the every countries. So I'm talking about that today. So when there is a patient, could you say, oh, I'm not feeling well today, I'm feeling indigestion, or I got a chest pain. And what the patient, sometimes the patient himself can call the ambulance. They press 999 and then they refer it to the related to the health department, which is the paramedics, or the family members can ring them. And when the paramedics go to that place, and they will do the ECG straight away. And there are different types of technician crew is there, and the fully trained paramedics are there. And then the technicians can do the ECG, but they can't read the ECG. But the fully trained crew can do the ECG, and they're nothing, they got every skills they got. They can intubate the patient, they can shock the patient, they can give the drugs, they can cannulate the patient. But when this kind of call goes, depending on what you're talking in the emergency call, they will send you 9 out of 10. They will most probably send you the trained crew, and this trained crew will reach there and do the ECG, and then immediately they will contact us. And there are some areas where we in North Wales, the valleys or the mountains, and in those areas the paramedics, they are not able to drive to our cardiac centers on time. So because of that timing, they use a airlift the patient, and they will bring the patient in the helicopters. or that is a role of a primary PCI coordinator like me. There are so many PCI coordinators here. They will make the decision. No, you're too long. It is more than 2 hours or 1.5 hours. It is more than taking long time. There is no point of wasting that time, because time is very, very important here. So that's why we make a decision, send the airlift and helicopter and bring the patient. And when they bring to NWCC, which I just put it as a North Wales Cardiac Center or any cardiac center, they go in the North Wales Cardiac Center. It's the role of a primary PCI coordinator to make the decision whether this is the STEMI or a non-STEMI, whether this patient has got a ST elevation MI or a non-ST elevation MI. And if there is a criteria are fitting, then they will immediately will make a decision to call the whole team who is on call for the PCI. And that team will come and then they will take over and will do the angiogram and the angioplasty, and then we'll send them to the CCU. And if it is a non-ST elevation MI or the old bundle branch, left bundle branch block on the ECG, and if it is not fitting the criteria, which we follow the NICE guidelines, BCIS guidelines, European Cardiac Society guidelines, there are so many guidelines, and each hospital has got their own protocols. And we follow the local protocols, keeping the reference of the national guidelines. And then if that is not fitting the criteria, we just don't tell, no, we are not responsible for that. We still advise the paramedics to take that patient to the closest A&E or closest emergency department or nearest hospital. And once they are here in the NWCC, which is a cardiac center, then we do the procedure angiogram or the angioplasty, and then those patients straight away go to the CCU, which is a cardiac care unit. And when they go to the cardiac care unit, if it is a night time, they will stay overnight until the next day morning, or maybe about 24 hours. And when they're all stabilized, because that's very, very common to get them a lot of abnormal rhythms they will get, and a lot of problems they will have, chest pain they will have mostly. So coronary care will monitor them, observe them, and treat them immediately. And then once they're stable, then we will send them to the cardiology ward. And either they can go there without any telemetry, which is a monitoring device. They can put the ECG leads, and there is a little monitor like a mobile phone, and they can put it into their pocket. We can still record them in the CCU on the monitor, but they're in the cardiology ward, because we need to encourage them with the independence. So they need to get back to the normal. And if they don't need a telemetry, then they stay in the cardiology ward, and then the doctors, the team, and the cardiac specialist, or we call it the MDT, which is a multidisciplinary team, they will review them and we will send them or discharge them home. And if it is not necessary to send them home, and if they need a further treatment, then the third part comes, which is a tertiary center. They go to the tertiary center. And this is a team, because when you talk about the journey of a cardiac patient, it is not just one person, PCI coordinator, or one doctor or one consultant doing all the jobs. Because here on an average, the cardiology consultant, I think in a year, they see about average of 120 to 150 patients. They do, that is a average in a year. They do the procedures for the PCIs, and that they are called as an interventional cardiologist. And these are always we look into the patient is the first in the health team, and it's here also is exactly the same. And if I look into this, show you this one first, and patient-centered care, and you can see the mission and the values are aligned with the patient, our goals, and our care is collaborative, coordinated, and accessible. And also the physical comfort and the emotional well-beings are met. And they are the top priorities, because we need to keep talking to the patients, because we need to win their confidence and everything. And then the family's viewpoints, they need to be respected and they need to be valued. And then when the patient family always included in the decision, because that makes a faster recovery for a patient. In a lot of places, we don't care about the patient, we don't care about the relatives, we just do what we want to do. And this is our package, and you pay this much, go and deposit this much money, and we'll get it treated. It's not like that. And also family welcome in the care settings. We need to provide, and we need to respect the family, and we need to provide them the facilities in those settings for them to, and then full transparency and the fast delivery of the informations must be given to the family and the patients. And that's why it is very important. So in this one, These are all the people involved, like, family members, friends, relatives, neighbors, carers, paramedics, whether it's a trained or a tech crew or untrained, and helimed or a crew, and the emergency department nurses, and cardiology, cardiac cath lab nurses, and the healthcare support worker, and then the primary PCI coordinators, CCU nurses, cardiac ward staff, and then the cardiac interventionalist, nurses, physiologist, radiographer, healthcare support worker, their secretaries, the receptionist. So there is a huge number of team. And then when the patients are on the ward, these are the nurse prescribers, because nowadays in UK and I think many places, the nurse prescribers role is come up. And Shishir, my colleague who is going to talk later, he's one of the nurse prescriber. And pharmacist's role come as well, because they come and talk to a patient if the patient need to a long-term medications and they need to their lifestyle changes and everything, then the cardiac rehab nurses will come. And when they go home, then the GP, which is a general practitioners, they follow up everything and they get all the informations. And we always use that S bar, you remember? And then community nurses will be sent all the information. Then if they needed after the surgery or anything in the tertiary center, then they will go through the physiotherapist and we just support them with the occupational therapist. And all these MDT is very, very important and the recovery of a patient. And but most important is center is the patient and the patient-centered approach. And this is one of the ECG where I'm just going to show you this one. When we do the 12 lead ECG, we say 12 lead, but there are 6 leads on the chest, which is V1, V1 to V6, and again they come and there are 3 leads, which is 1, 2, 3, and the AVR and AVL. There are 2 leads, and AVF there are 3. So there is if you can see here 1, 2, 3, AVR to AVF, and V1 to V6. So that's why we call it as a 12 lead ECG. And this ECG represents a different area of the heart where it is affected. When you look at the ECG as a PCI coordinator, who can just straightaway tell this vessel needs treated immediately. And that's why when you have a 2, 3, and AVF, these leads got a ST elevation MI, then we'll see the inferior walls. And then V1 and V2, which is the middle, where you are seeing it before with the conduction system, that's a septal area or the anterior septal. And then V3 and V4 just to left, just on the side of your chest, that is anterior wall of the heart, because heart is situated in a different position, not straightway facing front. And then lateral wall, which comes on the side. So all you need to remember is to make it very simple, like any kind of object, you need to see the front and the back, which is the anterior and the posterior, up and the down, which is the superior and the inferior, and obviously there is on the side, which is the lateral. So there are 3 main arteries which supplies the blood, and these main arteries can block and that can affect the flow of the heart and blood, and then it will cause a heart attack. So RCA, which is here, which is a right coronary artery, which is a left coronary artery, and the circumflex, which is the left anterior descending, which comes as a LAD and then divides into the circumflex. So these are the 3 main arteries which supply. And you can see in the ECG when there is a lead 2, 3, and AVF, it is affecting the inferior. And if there is a prominent R in the V1 and V2, then it will call a posterior wall. It's a similar way. V1 and V2 are the anterior and anterior septal. V3 and V4 are the anterior leads. And then excessive anterior, which is called as a 1 and AVL, and the V1 to V6. And when it is a circumflex artery, which is here, you can see that, and which is going at the back behind the heart, and that is called a lateral MI, or we can call it as isolated posterior MI. And I think we already talked about this one. So these are some of the pictures I'm going to show you. What is sinus rhythm? As if you can hear the noise sound and see the movement of these muscles. So these are the transverse sections of the heart, which is a normal sinus rhythm on the first top left, which heart is beating. You can see the electricity is going through the sinus node. And then that is a sinus rhythm, because you can see that yellow dotted lines going and the firing and supplying the electricity to the heart. And in the second one on the top right, which is a ventricular tachycardia, both the lower chambers, ventricles, are beating too fast. And then on the bottom left, which is the atrial rhythm, the electricity is only going up on the top chambers of the heart, which is atrial fibrillation, because they're not going through the conduction system properly, and they're just staying there. And when you can see, this is one of the dangerous rhythm, which is a ventricular tachycardia, and VT we call, and this is obviously the ventricles are beating very, very fast. And this is one of the ventricular fibrillation. Ventricular fibrillation or the ventricular tachycardia. See, this is a normal beat where you can see. And then when there is a ventricular fibrillation, the atria are not happening because the valves are not opening on time, because you need a systematic way to open and close the valves. And because of that, this ventricular fibrillation occurs, and then heart doesn't know what is happening. Because if you think heart is like a jelly, and this is one of the picture my colleague shared, which is during the surgery, this patient had a ventricular fibrillation. And where you can see, I'm not expert with the echocardiogram, there is a picture here, and this is a wall of the heart, which is a pericardium outside. And then there is a, all you need to is VT and VF are most dangerous one, and they need to be treated immediately. And then we'll just coming back to these, some of the rhythms. So is there any chance we are open with the quiz, Rajendra or Shishir, or we'll just carry on? We're running late.
No, it's not
Okay.
yet active.
Sorry.
The chat box is inactivated. I think before setting up the link, the IT should have set it up, but I don't think it's possible now. We'll continue,
Yeah.
but they've got a,
Okay, that's fine. No
I'll let
problem.
you continue.
So we'll probably share
Okay,
them on the email. Yeah. Okay. So these are some of the rhythms we're asking you. Then the very simple one is a sinus rhythm, and this is another one which is quite a dangerous one, which is as you can see, there is a cardioversion here, because this is called as a synchronization. When the cardioversion, there is a one is a synchronized and one is a unsynchronized. So unsynchronized, we give the high voltage of the shock we deliver here, and then with the ventricular fibrillation here, and then we just deliver immediately. And you if you are on your own, and if you know what to do, and we are here, like our level is up to the ALS level, which is, if you've done the ALS training, advanced life support, as per the Royal College of Resuscitation Council of UK, RCUK, and you can shock the patient if you recognize the rhythm. And if you are not trained or not anything, it's not a problem. There are certain defibrillators which you apply the pads on the patient's chest and switch the button on. Switching button on, don't not to get scared, because it's not going to deliver any electricity. You're just switching it on and the monitoring. But some of the machines will straight away read the ECG rhythm, what is happening, and they will tell you what to do. And they will tell you, please start charging, this is dangerous rhythm, and stay away from the patient, and press the button, and everything. They will prompt you everything systematic way. And as a British Heart Foundation is one of the biggest cardiac charity organization here, and that organization is delivering and supplying so many defibrillators, and their aim is to reach every street in the United Kingdom, so that they can put the defibrillators in every street, and they will reach the patients. And they also started training in the primary schools, in the primary school children. Even like my daughter is like 9-year-old, and she knows about what to do during the emergency. Even that child can use those defibrillators. The child can open it up and put the both the pads and switch the button on, and that machine will tell you. It's like a toy.
ಹಲೋ ನಮಸ್ಕಾರ ಸರ್, ನಾನು ರಾಜೇಂದ್ರ ಮಾತಾಡ್ತಾ ಇರೋದು.
Rajendra, ಹೇಳಿ.
ಸ್ವಲ್ಪ ಅದನ್ನ ವೆಬ್ಎಕ್ಸ್ ಅಲ್ಲಿ ಇದನ್ನ ನನ್ನನ್ನು ಹೋಸ್ಟ್ ಮಾಡ್ತೀರಾ ಸ್ವಲ್ಪ?
ರಾಜೇಂದ್ರ, ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ತೀರಾ? ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ತೀರಾ? Thank you. This is one of the ECG, which is a typical ECG, where you can see 2-3 AVF, their ST elevation, 1 millimeter or 2 millimeter we call, but it is a huge MI. Oh, sorry. There is a huge massive MI in this ECG, and there is again, there are so many changes in the lateral lead as well, septal lead. And this is why, when as soon as you see the ECG, you need to get scared. Oh my God, I need to get this patient quickly. That's how the primary PCI coordinator should be active. And this is one of the form we use, check sheet we call for the ambulance. So ambulance people, because the timing, we monitor the whole United Kingdom, because what time the patient started the symptoms and when they call for the help, and what is the Welsh ambulance service, and when they arrived, or the first medical contact, FMCs, and when the first ECG was done, and time accepted, door time and the balloon time, because these door time and the balloon time and these are monitored whole nationally, because this is very, very important, because I think in our trust we are keeping almost on the top of the gold standard, we call, we are achieved the gold standard, and we are maintaining that standard, because because we're very lucky, because when we built the new cardiac center, because there are very famous hospitals, but their cardiac facilities are very old and they're completely deep inside the hospital. And when they reach door to the needle, which means when the patients arrive to the cardiac center and then they go on the table of the patient, and when they had, experience feed that catheter through, and then the affected artery is opened up, and that's the time when you put the balloon, when they reach the hospital and when the balloon was put, that time is calculated. But for us, when the patient reached to the North Wales Cardiac Center, we got only just 2 doors to open. As soon as the first main entrance, then turn right to the cardiac center door, and then they're there. Even less than 2 to 3 minutes, the patient is on the table, and that buy a lot of time for us to reach that gold standard. And that's why a lot of centers are looking to change their entrance and those kind of things. And we write the ECG findings. Obviously, we need a hemodynamic stability, and whether the patient had a cardiac arrest or not, or any kind of abnormal rhythm, and was it resuscitated, whether the patient is intubated or anything. And we also look the past medical history, because it's very important, whether they had a history of stroke, whether they have got a history of dementia, whether they have got a kidney problem, because we have to inject a lot of contrast, and because of that we need to look into all those things. And then this is the way the patient comes to the hospital. As you can see, emergency transfer, the blue lights will come. When the blue light is on, everybody has to go on the side, and they have to give the way. And it is not that we have to block their way, because this is emergency, because the police, ambulance and the fire, these are the 3 emergencies we get on the road, and we need to, everyone should stay on the side and give the way to the ambulance. And the airlifting, when there is a valleys or the mountains, and where there is a very tiny roads, and where they cannot reach, and especially during the in our area, because it's a holiday destination, during the summer time it's very difficult to get one-way traffic, and that's why they always airlift them. And when they arrive to our hospital, this is like a scene at our entrance, and then this is a scene inside our cardiac center. And this is the reason time is very, very important. And I'm not going to go through that one, because we need all the blood investigations and X-rays, ECG, echocardiogram, and all those things. They all come secondary. And this is one of the coronary angiogram, where you can see there is a affected artery which was blocked here, LAD, left anterior descending, and then they opened it up. And this is the pre-stenting and the post-stenting angiogram. As you can see, there is no flow here. You don't see any flow. But whereas on the post-stenting, you can see there is a flow as well. So there's a mild diseases are there, but they can be treated medically, or they can be treated later on. But we treat if there are 2 vessels or more vessels are blocked, we treat the culprit vessel first. Then we'll go for the next later on, or they will stabilize first, because that culprit artery which is blocked, that is causing a problem. That's why it's a similar form we've seen it before. So as you can see, as we're running out to the time, so Shishir has to talk a very important lecture. So this is the main important thing. When from home to the family, then the paramedics, then they go to the airlift or a cardiac center. If not cardiac center, then the emergency department, then the CCU. And with the patients, maximum they stay, like 24 hours, and there are 2 different. One is a primary, which come as an emergency, but we have an elective as well. When the patients come as an elective, they come in the morning, get it treated, stents has been done, and they discharge home on the same day. And that's how the fast system is here. They don't need to stay at home in the hospital, and they will be much better. The recovery is better, and there are a lot of evidences that patient is feeling much better with their own family members, in their own bed, in their own house. And that's why we have a cardiac rehabilitation team support and the general practitioner to support. To summarize everything, so these are the basic understanding of the cardiac physiology patients. Patient's conditions, signs and symptoms, and the history are very, very important. And during the journey of the cardiac patients, which you remember, this is a poster, and this is very, very important. And then a systemic approach ensures an effective assessment, helps for the diagnosis, which leads to the effective treatment. The earlier diagnosis is better, and always look for the patient and feel for the patient, and look. And there are a lot of YouTube videos. I wanted to play them, but there is no time. You can just Google it into you can search on the BHF website, and you will see a lot of cardiac related stuff on the internet. And if you want to go for the guidelines, go for the BCAS, British Cardiothoracic and Society, Interventional Society, European guidelines, ESC we call, European Society of the Cardiologists, or we also follow the NICE guidelines. So these are the reference I can give you. So that's why you all, thank you very much for your valuable time, and stay safe in this pandemic. Thank you very much. So so before I go to the quickly, what I normally say, the heart, you just think at like a house. And when you look at a house, so you look into the house, like a flow, which is a cardiology, which is the flow is always with the pipes. And when that flow is going through the pipe, you remember there is a electricity also is needed. And that electricity, it comes through this conduction system. And when these like a valves are there, valves opening and closing, these are like a door or the windows in the house for the ventilation, you can say. So similar way they are helping us. So that's why, and these muscles are like a roof or the floor or the wall of the heart. So the similar way, so there are different kind of elements needed into this heart muscles, and to treat we need different specialties. And in the long run, there are so many patients who come to us, not everybody needs the non-STEMI people doesn't need a PCI. So non-STEMI, I think about 15% of the patients who are non-STEMI, which is non-ST elevation MI, they go into the failure. And when they go into the failure, it is very important that we need to identify them quickly and refer them to the tertiary centers. Like how we refer to our colleague Manchester, Shishir, he's going to talk more about the that side and the specialty side. And I'll hand over to Mahesh sir. Thank you very much.
Thank you, Raju sir. It was
Thank you.
very nice and very illustrative and very good speech and presentation.
Thank you.
I'm again thankful to you. Rajendra sir has requested me for a while. I'm transferring the session to him. By that time, I will do the introduction of the Shishir sir. Meanwhile.
Sure.
Sir, Rajendra sir, I have transferred to you. Sir, your mic is off.
You're muted, Rajendra.
Shishi sir, just wait.
Sure, yeah.
Okay. Thank you very much. You can continue, sir. I'll try to work on the background.
Yes, sir.
Okay. Thank you.
So our next speaker is the Shishir Kore sir, who is Ventricular Assist Devices Coordinator, who leads a team of the cardiothoracic organ retrieval, National Organ Retrieval Services UK, and the mechanical circulatory support nurse specialist at the Manchester University Hospital NHS Foundation Trust. As a part of wider heart and the lung transplant team. He is passionate about improving the patient's experience and the health-related outcome through the effective multidisciplinary collaboration and the patient engagement. With the outcomes that are among the best in the world, the Manchester Ventricular Assist Devices program is one of a few centers worldwide that helps set up and proctor new and upcoming centers across the globe. He is a part of UK specialist collaboration that developed emergency care guidelines for the management of the people with left ventricular assist devices, is currently involved in setting up the advanced ventricular assist devices coordinator training programmer in Europe, actively involved in the NHS specialist commissioned services audits and industry lead clinical trials. He has co-authored several publications and regularly speaks at the local, national, and international conferences. Shishir graduated with the bachelor's degree in the nursing from the Kaylis Institute of Nursing Sciences, Belgavi in 2001 as a part of the first cohort of the Rajiv Gandhi University of the Health Sciences. He further obtained the postgraduate certification in the advanced nursing studies and is an established nurse prescriber. An avid hiker, he is often seen with the like-minded people in English, Welsh, and the Scottish mountains. He has a quirky sense of the humor, enjoy talking to the people, and is keen to meet everyone at the conference. I think this is very brief intro, and I hope you might have the idea about him in brief. So I am welcoming the Shishir sir for his talk in the further session.
Thank you, Mahesh. That's really, really kind of you. And thank you for having me on this session. I'm just going to wait for Rajendra to run a few things. He's working there in the background. In the meanwhile, I'll try and see if I can get my slides on, but we'll wait and see what he has to show all of us. Rajendra, over to you.
Sir, if it is possible, you can share your PPTs.
Okay, I'll just wait to see if Rajendra wants to share something, and we'll go after that.
No, actually, I'm trying my level best here. No, I don't think so. It's not possible from this side now.
Okay. Okay.
Yeah, the reason is that, like, no, if I change the setting now, everything will disconnect.
Okay. Okay. No
I
problem.
think
Thank you
so,
for trying.
because it's not enabling me now during the meeting to change the setting.
Okay.
I have
But thank you.
transferred the host to the Shishir sir, and we will continue the meeting.
Sure. Thank you. Thank you, Mahesh sir. Thank you, Rajendra, for trying. We know there's always some of the other technical issue that comes up with these meetings, but we'll carry on forward, and I'll try and quickly finish. I know we are quite strapped for time. Let me just bring up my presentation, and I'll make a start.
Thank you.
Can I quickly check with everyone? Are my slides visible?
Yes, it is started. Just few
Okay,
seconds.
thank you.
Yes, it is started.
Sure. Thank you. Thank you so much. I'll let it come on. Give me a couple of seconds.
Yes, sir.
Okay. Following on from Raju sir's presentation, I think it's quite difficult because they do an excellent job at the secondary levels. Now, I want to highlight the fact that 1.4 million people in a year throughout the UK, and the UK is a small country, are saved by the interventions that they provide. And this,
dedication, devotion, and more than that, values.
I'll just wait for people to mute their.
Netravati Ganesh, please can you unmute? Oh, sorry, can you mute your speakers?
Thank you. Thank you so much. So it's a very difficult thing because for these 1.4 million people who suffer a cardiac arrest, it takes less than an hour for permanent cardiac damage to occur. So they do a tremendous job. And from what Raju sir has been saying, it takes a lot of effort by a numerous amount of people and a very well coordinated effort to get this PPCI correct. However, because of the nature of the problem and because of the extent of the problem, we know that many people do sort of suffer the permanent damage to it. So that's when the advanced sort of cardiac care team comes in. Now that's a service that should not exist, but it does exist because we do get such people. Now, Rajiv can Putilinga Gowda, please can you mute it? Yeah, thank you. Thank you very much. Now, there's an excellent point that Rajiv made that you have to visualize the heart or any organ or any system within the human body as a three-dimensional model. It's throughout my learning in university, and I'm sure it's yours as well, we always look at pictures in textbooks, on slides, as a two-dimensional figure, but that's not how it works. It always works in 3 dimensions. Now, here's a good example. I don't know if you can see the animation moving on my slide. It's a cutout of a heart, and it's just the right and left ventricle moving. Now, this is a very close representation of how the heart or how the ventricles actually contract. Now, if you see, the ventricles contract radially, they contract longitudinally, but also they've got this side-to-side movement, which is what we call a corkscrew movement. So based on these three sort of mechanisms, that's how the blood is expelled from the ventricles into the systemic and pulmonary circulation. Now, why is that important? It is important because the mechanism of failure is entirely dependent on how the ventricles function. So that gives us a good understanding of what heart failure is and what are the sequelae, the repercussions of the failure of these two parts of the heart with their function. So moving forward, why are we doing this session? Well, we basically want to get a good understanding of heart failure and how it's managed, but more so, we'll understand a few things that are important. First is, what is heart failure and how do we classify it? Second is to understand the progression of it. Third is, what care do we give? Is it just treatment of the heart, or do we care of the patient as a whole? So that's holistic care. The various options we've got, and ultimately, we'll also look into palliation and end-of-life care. So we'll look into what basically the heart function is. So these are some live MRI images. These are a bit in slow motion so that we can have a very clear idea of how things work. Now, I want you to look. I don't know if you can see my cursor. Well, this is the image of left ventricle in a longitudinal axis. So the blood comes through left atrium into the left ventricle. Now, you can appreciate if you look closely that this is the mitral valve there, and the mitral valve is connected through chordae tendineae to the papillary muscle. When it opens and closes, the blood flows through from the atrium into the ventricle, and then when the ventricles contract through the aortic valve, blood flows into the ascending aorta. Now, I want you to look at what the muscle of the left ventricle is doing. When in diastole, it thins out, and in systole, it thickens in, and that's when the blood is pushed out. But if you look, there is consistently and there's a uniform contraction, uniform thickening of the muscle throughout the globe, throughout the outer edges of the heart. Now, that is very important in understanding where the failure comes from and how it's affecting the circulation. If you look at the 4-chamber view, you see that's the left ventricle, from blood flowing through from the left atrium into the left ventricle, and this is the right side. But even here, you can see the muscles contracting quite well. Now, that is important. Do bear that in mind. I'll talk about it a bit more in the next couple of slides. Now, here is a picture of the heart contracting in real life, in real time. So blood flowing through left atrium, which receives blood from the pulmonary. May I request everyone to please mute their Bhargava. Thank you, Bhargava. So if you look at the images, that's in real time. You receive the heart receives blood into the left atrium from the pulmonary veins. So the blood flow, as you can see, where the cursor is pointing. So on that side, these are the right pulmonary veins. These are left pulmonary veins. Blood comes through into the left ventricle and is pushed out. But again, I want you to look at the borders of the heart there, and you look at the contraction of the musculature. It's uniform throughout the edges. You can see the muscle contracting and thickening right and left. And on the other picture, you can see a cut section. This is the short axis view, where you can see the left ventricle. It's like a cone, and the muscles are contracting evenly. The circular structure that you see is left ventricle, and the right ventricle is a thinner musculature, which is attached to the septum. Now, to gain an understanding of heart failure, let's take an example of what Rajiv said, that once someone has a heart attack, if the time from when they have a heart attack or myocardial infarction to the time where it's resolved, if it's longer than a couple of hours, you risk permanent damage. So then over months, years, people go into heart failure. So what this means is that the condition worsens and gets to a point where all the therapies that are there and all the medications, all the treatments that we can give no longer work in them. And in spite of all the support they get, the heart does not work as it should. So what do we do then? Sorry, can I request everyone please to mute their devices? Thank you. Okay, I'll carry on. It's important to understand what is heart failure and the extent of it as well, so that we can treat it with appropriate therapies. Now, the position statement that the Heart Failure Association came up with, these were revised in 2018, and a couple of important things is that it's the cardiac dysfunction if the ventricular output or the amount of blood that's put out by the left ventricle is less than 30% of normal, then we fall into the category of heart failure. And there are several other hormonal factors. There are several other things that we can look into or tests that we can do to ascertain whether it's the extent of heart failure. To classify this and to understand where and how worse it is, there are three different methods or three different schools of thoughts. One is the American Cardiologists Association, American College of Cardiologists, then there's the New York Heart Foundation, which came up with the functional classes, and thirdly, the INTERMACS. But if you look at the graphs up here, it progresses from A, B, C, D, or 1, 2, 3, 4. However, with the INTERMACS profiles, it goes in a descending order. So what does that mean? So once in heart failure, the heart progressively declines, or the condition progressively declines from A to D, or 1 to 4, meaning that if they are in class 1, there's little limitation in physical activity. People are still able to go and do things. And then when it's 2, 3, 4, it gets worse and worse. However, the D and the classification 4 from the stages and the functional classes, they do not define it well enough when they go into advanced heart failure. But we need to understand which sort of section they are in so that we can target that with appropriate therapies. Now let's look at this image of a person in heart failure. Compare that to the images that we've seen before. If you look at the ventricular function, you can see the bottom bit of the heart, or the apex, including the apical regions of septum and the anterolateral walls. They are not moving. And you can see, you can appreciate the blood flow as well. It's not as robust as it was with the normal heart. So this is what heart failure does. The heart is not capable of pushing blood through the systemic or the pulmonary circulation for the body to survive or thrive. You might have heard, now this is one of the interesting things that we come across, but you might have heard that people die of a broken heart or when they have a huge emotional event in their life. And it's true. There's something called as Takotsubo cardiomyopathy, and it's usually prevalent in women over the age of 40 when they have a huge emotional trauma in their life. The heart fails, the left ventricle fails, and the image you can see, radiological image, it's similar to this little vase, and that's what is that's a Japanese term, or it's a vessel that's used in Japan to capture octopuses. It's called a takotsubo, and hence the name. But there are various. I put this slide on to highlight that it's not just organic factors that affect heart failure or the normal functioning heart, but it's also emotional stresses. Why do we have to treat heart failure? This is a very good slide that shows the depreciation or the worsening of quality of life in people with heart failure. Initially, when you get a heart attack or there are various other valvular problems, there are various other cardiomyopathies, genetic factors. Once they precipitate heart failure, you have a huge dip in the way you lead your life. Then after some treatment, the quality of life comes back. But here's the thing about heart failure. Now, there was one of the questions, I don't know if everyone remembers. Heart failure cannot be cured because once the heart starts failing, no matter what you do, it will keep on going worse and worse. No amount of medications, no amount of treatment is going to bring that heart back to normal. There's always be some amount of heart failure. Now, various amounts of therapies are there. There are advanced heart failure therapies, which we'll talk in a little while. There's heart transplantation. But if you look at this graph right from the top, where one is fit and healthy, over the course of time, the quality of life goes down and down and down, and it does not improve. It might get a little bit better with some therapies, but there's always a decline. So it's important. So prevention is the key, and that is what should be the main focus. However, we always have people who do fall in heart failure. So there are some management options available, and we'll look into those. But why do we need them? First of all, is to improve the symptoms. Second is to delay disease progression as far as possible, which then prolongs life. And most importantly, it improves the quality of life, because that ultimately, that's what is the essence of healthcare. You want to improve the quality of life of a person, not just prolong their life. So we'll now see what these treatments are and what are the options available. But also we need to look into whether these treatments are effective for people falling in those categories. And is there a method for us to measure the efficacy? Because you can keep on giving treatments, you can keep on come up with innovations, throwing in therapy after therapy. But does that actually work in those group of patients, or for that individual for that matter? So let's look into that. As for advanced heart failure, the gold standard is heart transplantation. So once they have heart failure, that cannot be cured, but you can put another heart in. Why is it a gold standard? Now, over years and years of research, they have found no matter what you do, the longest time a person can survive and the best possible quality of life that they can get is from heart transplantation, which is roughly from 5 to 10 years. But there are many people who go on to live for 20 plus years and lead a very good life. But then not everyone can have a heart transplantation. There are several sort of criteria that one has to fit, that they should not have other comorbidities. There are many contraindications for that. And plus the fact that donor hearts are not available freely, or there are not many donor hearts. Not everyone gets them. And the people who are eligible for them, they are carefully chosen so that that donor heart is not wasted. So that we've got to think about people who aren't eligible, people who are quite elderly, who can't have a transplant, or who have got other comorbidities, like they might have kidney diseases, liver diseases, they might have neurological problems. What do we do about them? And that's called bridging the gap. So we look at all the options available. Again, I'm going to enhance that as every medical professional, and more so for nurses, because we spend the most time with all these patients, we have to look into enhancing the quality of life of these people, be it on a short term in ICU, be it in a short term in emergency department, a bit longer on the wards, or as community nurses on a long-term approach. But the important thing that any therapy involves is improving or enhancing the quality of life. So what is this quality of life? It's basically how well a person feels within themselves. So it involves everything like the health, physical health, psychological state, the level of independence that they have, that they don't have to depend on anyone to feed them, to shower them, to take them out, waiting for someone to come in and do the shopping for them, or waiting like elderly parents waiting for them to come and say hello, take them out for a day out. So all these things do matter to a person. Now, it's very easy for us in our age when we are able to independently go outside or independently do things. But think about people who have got debilitating conditions, who have to depend on other people for the smallest of things. Now, that does bring down, or in their own context, bring down the quality of life. What are their social relationships? Is it mutual or is it one-sided? Is it paternalistic? What about their personal beliefs? Are they taken into account? Do they matter to other people who are looking for them? So all of these things come together to form or to define quality of life. And it is different for every individual. So we have to have individualistic care, which takes into account what is important for a person, but also that it is holistic. So here's a very good sort of representation of what the research over the past 100 or so years has come up with. And it's fairly effective. It works in most of them. And based on the classes, I remember I was talking about the classes, put the slide up again, that you need to understand the classes or the classification of heart failure to know which therapy works best or is most effective for that class. So for New York Heart Association functional class 1, you use, if they are hypertensive, treat the hypertension, treat other comorbidities. If there's coronary artery disease, use all sorts of medications that help with those. Importantly, primary prevention is always important. You reduce the risks that are involved. Education is quite, well, it's always said that we need patient education, family education. The importance of a timely and effective education is critical to the success of any therapy. And then you use a medication. Now, one of the things Rajiv was saying, as nurse prescribers or any prescribers would know this, is people, when you prescribe them, you give them medications to take for a week, they will start taking it, and then midway, half of them leave it. So most of the therapies, or I'd say 40 to 50% of people who are prescribed things do not take the appropriate medications, which is why the outcomes are not as good or not as we expect them to be. So coming back to the classification, you use all sorts of different tiered or stepped models to increase the amount of therapy in people. So for class 2, you use your beta blockers, your ACE inhibitors, your mineralocorticoid receptor antagonists, which is spironolactone, eplerenone, those kind of things. You use multidisciplinary teams for cardiac rehabilitation, the physios. You treat the iron deficiencies. And there are newer classes of drugs like the sacubitril, valsartan, which help in. Then you consider a class of drug called ivabradine, which reduces the heart rate. Now, here's a interesting piece of research. If people who are in heart failure are in sinus tachycardia, their survival is far less than people whose heart rates are less than 70, which is where this ivabradine comes in. So all of this research has been done, and it's very well laid out for treatment, which is why we need to have a proper understanding into the classification. Now, thirdly, as the heart failure starts getting worse, that's when you need more and more input. So when you get to a point where they are end stage heart failure, class 4, that's where the end of life discussion comes in. Palliative care treatment, advanced directives, you might have heard these terms. Now it's too big a topic to be discussing at this point, but maybe we'll have the discussion later. Then there are some options for called as ventricular assist devices. These are mechanical circulatory support, which help the heart pump blood out. Ultimately, there's gold standard, that's transplantation, which makes a huge amount of difference in majority of patients. And if that doesn't work, if they're not eligible, then palliation is the last step in the process. So why do we need the Intermax levels? Because timing is essential. Timing is the key. Too soon, it does not give them the benefit of the treatment. Too late, and the treatment don't work. So what is this Intermax and what is MCS? MCS is mechanical circulatory support. So you use mechanical devices which are not part of the body, which are not organic, to help circulation, be it pulmonary circulation or be it systemic circulation. So there is this Intermax, which was coined up by surgeons and cardiologists worldwide. So it's interagency mechanically assisted circulatory support. So they've got this classification, which goes in a decreasing order from 7, which is equivalent to New York Heart Association 3 and 4, and it gets worse and worse, and 1 being the worst. So if someone's in Intermax level 1, they are in what we call crash and burn. So if they do not have an intervention in a tertiary setting, they will die. So this stepped model, again, the graph represents that the timing, whether it's elective or emergency, for each level of the classification. Now, this is something I found on Pinterest, on Google. You can see it. Here's a very good example of to understand the classifications, what's important, what therapies are available. So the data. Now let's take an example of a patient who's had an MI or heart attack. When they come in, we take all the data, we take all their readings, and then go on further to do all the investigation. So we get a lot of information out of that. We try and link in what's happened. So if their TROP-Is or troponin T levels are high, we know for a fact that they might have had an MI. If the ST segment is elevated on ECG, we know that it's MI, or they've got heart attack. There's a blockage in the coronary arteries. But then linking it to the treatments is an insight that people have or medical personnel have. However, using all of the treatments that are available and not just one is, of course, wisdom that comes with experience, with the consultants, with the senior nurses, with the senior physiotherapists, with the whole team that's there. And most importantly, the understanding that each and every aspect of the data, if you correlate to that to the first one here, each and every element is important, and each and every element is the key in treating every individual. So this is where holistic care comes in. So you have to treat every piece of information to be critical to the treatment of every patient. So now let's look into what the mechanical circulatory support devices are. There are several that are available. The first one I'll start off with is an Impella. So when the left ventricle has had an insult, by insult I mean it's had some sort of event where it's not able to pump blood effectively. So what do? You try and minimize the pressure that's put on the ventricle to pump the blood. So here are some devices. The first one is an Impella. It's a catheter that they put through the artery. It might come in through the groin. It might come in through the arteries in the hand. Mainly it's the groin because these are bigger sort of cables. So that sits beyond or through the aortic valve into the left ventricle. It draws blood out from the end and pushes it out beyond the aortic valve into the systemic circulation, thus reducing the pressure load on the left ventricle. So that's an impeller. The second one is intra-aortic balloon pump. I don't know if you've heard of it, and I'm sure a lot of people have heard of it. So this is something that there's a picture of or a little video of the balloon sort of inflating and deflating. So what it does is it inflates when the heart is in diastole, which means that it'll try and push blood away from the heart and back towards the heart as well, so as to improve the coronary perfusion. When the heart is in systole, it collapses so that the blood can easily flow past it. And that in turn reduces the amount of pressure or the workload the heart has got to do, the left ventricle has got to do, plus also increases the coronary perfusion into the coronary arteries, which is important for the cardiac muscles. A step further, there are several options available. There's something called as VA ECMO, that's veno arterial extracorporeal membranous oxygenator. So basically it takes over the function of lungs and heart. This is there when people come in. If you remember the classification into Max 1, where they are crash and burn, where the heart and lungs are doing nothing for them. If left, they'll die. So they put them on the big cables, big tubes going to the arteries and veins, which draw blood out, oxygenate, and then push it back into the circulation, thus keeping the circulation going and keeping the person alive. So VA ECMO is one. There's another one called short-term single ventricular support, or it might be biventricular support. So both the ventricles, they use centrifugal pumps. And what I mean by centrifugal pumps is it's basically like a water pump. The pumps that you use at homes to pull the water through from the tank downstairs to the overhead tank. So the principle is same, but these are a little more high-tech because they have to work with the circulatory system, so infection control, breaking down of the RBCs. So a lot of things are taken into account into devising these machines or the pumps, and they work in keeping the circulation going. So the previous ones were for shorter term support. If the heart does not recover and is needing longer term support, what do? So you use the ones that can be put in or implanted for a longer term support, which is a ventricular assist device. These are long-term devices which stay inside the body, which have got some batteries. If you look at this little picture here, it's a pump that is fitted to the apex of the heart. The inflow cannula, the little tube that you can see here where the cursor is, all of that sits inside the left ventricle. It pulls blood out, spins it around, and pushes the blood into the ascending aorta. This is how the systemic circulation is kind of resolved within with such devices. Now, how does this device work? It's connected to the brains of the unit or the system controller by a set of cables that is attached to the pump. And for any electronic devices, it needs power. So they can either be powered by mains when they're at home, or when they're out and about, or they want to go out, they can use a set of batteries which last for a good 15 to 20 hours. Now, why do we do this? Because again, coming back to quality of life. So we want people to be able to do and live their life as they want it, so that they live a fruitful life, and they're able to do and they're able to achieve what they want in life. So improving survival statistics, improving survival and outcomes for people in heart failure, as well as quality of life, is essential. There are various up-and-coming options that are there. So there's total artificial hearts as well. The one up here is called CARMAT. It's undergoing a lot of clinical trials now. It's been authorized, or it's been okayed by the FDA, and it's got a CE mark. So people whose left and right ventricle have failed are eligible to have this. So it keeps them alive until they get a heart transplant. Coming back to the holistic care quality of life, what is it that we look into? So first, there are several things that we have to look from a treatment point of view. First of all, after the treatment, the outcome, is it what the patient wants? So you don't want, if the patient does not want to be bound in a bed, just barely alive, not able to move his hands and legs, with someone constantly feeding him 24/7, if that is not acceptable to the patient, why do we as medical personnel or family members, if you like, want to put that in that situation? So it's very important to understand what a person wants. So the quality of life. Are their physical symptoms going to improve? Is their emotional status going to improve? Are they going to be able to be productive, functional status? That's what it means. And what are the costs? Cost to the family, cost to the hospital, cost to the nation, cost to the economy. Is there a cost to the family members, to the caregivers like nurses, to the wider source community support? Does that put a lot of burden on it? Is it financially viable? Then with all of this, do they actually improve? Do we learn as an institution from these kind of things? And what about the other hard or problems that they might have? Does it affect the treatment, or does the treatment cover all those aspects? And lastly, we also have to start looking into advanced directives, end-of-life palliative care, because death is inevitable. We should stop considering death as a negative thing. It's coming to everyone. It will come to all of us. We have to try and promote, like I said, there's a phrase, quality of life is good living. And sorry. Oh. Okay, sorry. I thought someone was saying that. Okay, I'll come back to it. Quality of life is important when a person is living, but also we all know that we are eventually going to die. So why not invest our time and invest our thoughts into how well we want to die? So quality of dying, quality of death, quality of end of life is as important for us as medical professionals, especially nurses, to be thinking of all those things, because all these advanced disease conditions, we know the end point is going to be death. So that time frame where people are dying, we have to make sure that they have a good quality of the time that's left, so they're able to spend with their loved ones, they're able to have their end wishes taken care of. So quality of death, quality of end of life is as important as quality of life. So that's something I wanted to highlight. But to do all of these things, it takes a proper team, or it takes a full team to achieve good outcomes. Now, this is my clinical director. This is a team I work with. So Mr. Venkateshwaran, he's Professor Venkateshwaran now. He is our clinical director. He leads the transportation and the cardiac surgery team within our hospital. He's a world-renowned scientist. This is him giving a talk in Germany, in Austria. And along with him on the other side is Dr. Stephen Shaw, who's the lead consultant cardiologist. He's the ventricular assist devices lead within our center as well. So I work closely with these, the surgeon and the cardiologist, and we make sure that we work as a team. Now here's him presenting, if you see the red box, presenting that it takes a team to actually make a huge amount of difference. So, which is why our outcomes are among the best in the world. And you ask any center, like our team is highly regarded. Their opinions do matter, and they work as a team rather than, there's no hierarchy that I'm superior, I'm this. Of course, decision making, there has to be a hierarchy, but when it comes to patient care, there's no hierarchy. Everyone works on an equal level. So there's our team, and like Rajamate said in his slides before, team consists of multidisciplinary faculty members. So we've got surgeons, we've got intensivists, we've got cardiologists, social workers, again, very important, they play a huge role. Community teams like the district nurses, the community nurses, there are pharmacists, there are general practitioners, we've got dietitians within our team, clinical psychologists. So all of this, so if you look at the specialties of all the people, we've got physiotherapists and occupational therapists. For functional status, if you remember in one of the slides, that's important for people in quality of life. Then we've got wire and transplant coordinators, that's us. We've got nurses, ICU nurses, A&E nurses. We've got specialty teams, specialist nurses. Then we've got ward nurses. They are also important. But also we consider the family member or the caregiver as part of the team because they live with the patient for long terms and their input is as important as anyone else. So that's our team. Here, one of the major aspects of specialty areas of work is that it's not quite known within the wider team. So what we do is we all take they were presenting at various centers. Two of my colleagues on the right-hand side, they were presenting at Rajiv Maitri's institute where he had invited us. So we collaboratively work with them. So it's important to know what the options of treatment are and not only just give patient that treatment, but also involve people or other centers in their care because if something happens, we need their support. So it's collaborative working, not just collaborative working within one hospital, but throughout a wider region to achieve good outcomes. There's a consultant here, again, presenting at their center. This is one of my colleagues presenting in Asia. This is me with our patient. So our patient volunteered to come out to a different conference in Austria and presented how he felt after his device. I'll quickly flick through. I know I'm aware of the time, so I'll quickly flick through. So if you see, that's the X-ray, and you see that metallic structure, a little cannula which sits inside the heart. It draws blood out from the heart and then pushes it back into the ascending aorta. This is how it helps. It assists the ventricle in circulation, which is why it is called the ventricular assist device. Now, these are some three-dimensional pictures of how it actually looks when it's inside. So that's here is the cannula. Yeah, here's the cannula, which is inside the heart, draws blood out, and that's the outflow graft, which then attaches to the ascending aorta right around there. So why do we use them? Without going too much into detail, we use them to keep people alive and keep their quality of life well enough till they get a transplant. Sometimes, or some of the causes for heart failure can be acute. It can be viral cardiomyopathy. One of the things that we see quite often is pregnant women or women who have given birth, they end up having postpartum cardiomyopathy, which means the heart fails to an extent where it puts them into a huge risk. So those people have these devices, and then after a year or so, the heart recovers. So the function of the heart comes back, and then we are able to take it off. So that's bridge to recovery. There's something called bridge to candidacy, where again, there's a lot of things that we have to consider before they are eligible for a transplant or for one of these devices. So if that is unclear, then we put these devices in so we can investigate further, make sure that they become eligible for transplants, and then put them on the transplant list. But that's bridge to candidacy. Destination therapy is people, this is not sanctioned or commissioned within the UK, but it's done in majority of the other countries where LVADs are available as an option. So destination therapy is where people cannot get a transplant because of other factors. Then they have the LVAD put in for life. So it's destination, lifelong support. Why do we need VADs? This is a very good slide which represents the need for mechanical circulatory support. Now, if you look at the line here, that goes from 93 to 280 odd. So that is the number of people who are on the transplant list year on year. The blue line indicates how many donors are there. This is specific to the UK. And the gray columns are how many transplants we perform each year. So if you look, the number of transplants performed, and if you compare that to the number of people who require a transplant, there's always a gap. Now, year on year, in 2014 and 15, within the UK, we had 181 heart transplants. Yet, we had 267 people waiting for a transplant list. Now, out of 267, 181 had transplant. But the following year, we again had 195 transplants, but then we also had further 248 people on the transplant list. So no matter how many transplants we keep doing, we'll always have people who have advanced heart failure who will need transplants. So not all people who are waiting on the heart transplant list get a transplant. So what do you do with the other people? Previously, before the LVADs were available, those people used to die. They used to be palliated. And if they didn't get a heart, they would die. But now we've got this option. We've got this option where this gap of almost 90 people, 90 patients, they will be put on an LVAD where they'll keep enjoying life, they'll feel healthy, the quality of life is great, and the disease condition does not progress further, and they can wait for a transplant. In fact, it's so helpful that while on an LVAD, because the circulation is improved and all the perfusion to all the major organs is improved, they are in a better condition physiologically to have a transplant than someone who does not have an LVAD. So very quickly going through what the LVADs and circulation is. Now we've seen that's a little sort of animation of how things work. So the rotor is made up of 8 really strong electromagnets. The blood is drawn out, is spun around and pushed through. So a little cutout of the working of the pump. And I've actually got a pump here, which I'll show at the end of the slides. I've got a actual working model. A couple of things to consider. I'll go very quickly through this because it does not do justice to the whole topic. For VADs, you need a huge amount of blood coming through or adequate amount of blood coming through, and then that's when the pumps works at its best. Now, the other important thing to remember is that these devices are ECG independent. So if the heart is in sinus rhythm, the pump will still work. If the heart goes into atrial fibrillation, like we've seen from the slides from the previous talk, from Rajametri's slides, it does have an effect on circulation, but the LVADs will keep working. If someone goes into atrial ventricular fibrillation, the heart is not able to do anything. But people with LVADs will still have the circulation going. Now, I have seen on my own calls on numerous occasions that people have come and say, "Oh, I feel a little bit under the weather. My breathing's a bit off. I don't feel that great." And then we looked at everything. The pump was working fine. They were alive. They were walking. They came walking into into A&E. We connected everything. We did a 12-lead ECG. We thought the ECG machine was broken. We did it 3 or 4 times only to find out that these people were in ventricular fibrillation. So if it was anyone, any healthy person or anyone else without an LVAD, if someone has a ventricular fibrillation, they'll drop dead within seconds. Now, these people were came into A&E walking because these pumps kept on circulating the blood. So there's a lot of advantages for people with LVADs in this regard. The other important thing is that they are afterload sensitive. Now the pump will keep on spinning and pumping blood through, but if the blood pressure is high, that's what afterload means. If the blood pressure is high, they won't work very well. So we carefully titrate their blood pressure medications to keep their blood pressures between 60 and 90. And because it's a mechanical device and because there's a foreign pump attached, and which is where the blood flows through, they've got to be anticoagulated so that clots don't form. I'm going to skip this bit. It just talks about a little alarms, but I'll show you the actual model by the end of the talk, and I'll show you what the alarm sounds like. It's something that the pump tells us, but when it's not working, there are hazard alarms, which means there's imminent threat for the pump to stop working and subsequently the circulation to stop. Or there are advisory alarms where the pump keeps saying, right, you've got to change the battery, or I don't have enough power, so put a new battery on. I've got some malfunction going on. Can you look at it? It gives a clear indication. So I've got enough time to look into it. we look after, there's lots of complications that occur. If I just go back a couple of slides, if you look at this little picture, these are the sort of common complications that happen with people who've got LVADs. So hemorrhage, embolism, ischemia, you get valve dysfunctions, right heart dysfunction, which comes from the extra amount of stress that's put on the right side of the heart because of the LVAD. We get autonomic dysregulation. Well, that's something which has been recently studied. People with LVADs have got huge amount of sympathetic activity that creates a lot of differences in the way blood pressure can be managed. Then there is what we call AV malformations. There is acquired von Willebrand disease, where one of the key components of clotting is destroyed by the pump. Hence, they are at a higher risk for bleeding. Then there's thrombosis, this failure of the pump. So these are sort of complications. For that, and to prevent it, keep a close eye on them, we get them into our clinics. And we do all these things that we do. We look for the working of the pump. We do echoes to see hearts working well, vital signs. We check their neurological, psychological functions, their diet, their nutrition, health, physical capabilities, all the routine bloods like your full blood counts, your liver function test, coagulation, renal function. So all of this is done not just by the consultant, not just by the nurses, but the whole team is involved. So every time they come into a clinic, the cardiologist sees them, the nurse sees them, the VAD coordinators, that's us. They are also seen by the dietitian, clinical psychologist, the social worker, the physiotherapist, and we maintain their coordination. So it's a multidisciplinary approach that we've got, which reflects in the outcomes. But these people are not just based in the hospital. They go home, they live lives with their families, they go out and do so many things. So what happens if they've got a problem? They have got us as a team on standby. So there's 7 coordinators, there's consultant surgeons, there are senior registrar doctors, but we as VAD specialist nurses, we are the first point that they contact. So any emergency, they ring us, and then we resolve all of that. Now, this is something that we worked at a national level. There's not only 1 or 2 devices, there's different kinds of devices. So, and there's 6 centers within the UK who perform these kind of surgeries or offer this treatment. So we all met together and we sat together with the ambulance chiefs, ambulance trust chiefs, the resuscitation council, the cardiologists, cardiac surgeons, VAD coordinators. We came together and came up with an algorithm for the ambulance crews to manage emergencies in people with VADs. That's a free open access article. If someone is quite interested, here's a link to it. Now, the mechanical circulatory support is there for people to keep them alive, to eventually go and have a transplant. Because transplant, if you remember what we said earlier on in the topic, is the gold standard. It's the ultimate in the treatment for heart failure. So that's again a huge topic to talk about transplantations, but I'll give you a very quick overview of what the process is like and what my role is, me and my team's role is. So basically, it starts off with donation. So for heart transplantation, you need a donor. So the donor is, there's a huge amount of collaboration within the UK, which is led by NHSBT, which is National Heart Service Blood and Tissues, Blood and Transplant. So they have got specialist nurses for organ donation, which work closely with the intensivists in all hospitals throughout the UK, where the diagnosis for either brain stem death or whether the eligibility for donation after cardiac death is done. So when a person or a donor is found out, the referral is made, the organ donation nurses then have a discussion with the family to see if they are willing to make the donation, if they're willing to have their loved ones' organs donated to Mary's Member. Now, you have to remember that one person can save or improve lives of up to 15 people. So organs from one person can be given to 15 different people. That completely changes their life. and it's one of the most altruistic, and it's one of the best things a human being can do. Because if you pass away, you're just going to take the organs and they're just going to turn to soil. So why not help other people? That's the idea behind donation. So when the consent is given or the assent is given, the evaluation of the whole organs, the tissue typing takes place. Then we've got a national offering system where there's a core hub which matches the organ donor to specific recipients, or it offers it out to centers who perform transplant surgery. And once they do that, this is where my team comes in. So we are the retrieval team, which go out to different hospitals throughout the UK, sometimes to Europe, to go there, assess the viability or assess the function of the heart and lungs, make sure that they stay in that condition. So we optimize organs, we optimize heart and lung function. And then once it's accepted, and once all the preparations are made within the transplanting center, we then, with the surgeon, harvest the heart, procure the heart, take it out, preserve it, put it in appropriate boxes and transport them in a timely manner, which is quite important, so that they can be transplanted. Now let's have a very quick look at that. So as my responsibility, I'm a donor care practitioner. I am a specialist nurse for organ retrieval. So when we go out there, we assist them, or we have to identify that this is the correct donor, which obviously identification is important. We go through the medical history, we check the consent, we see the documentation, and at every critical juncture, we keep communicating all the findings with the recipient center where they are going to do the transplant. Now, I'm one of two members within my hospital who've been trained to float swans. We do bronchoscopies. We take transesophageal echo images, and then we send it out. So based on those findings, the consultant surgeon at the other end, he will either accept or decline the heart. But also, it also depends on what the finding is by the surgeon when they open up the chest and have a look at the heart. So what is key things that we do? So we communicate findings, we visualize, inspect, we check a lot of things to make sure that the organ function, the heart function and the lung functions are good enough for them to be then transplanted. So here's how we travel. We usually travel by ambulances. If it's a journey which is more than 3 hours, we usually fly to different areas. But if you look at the kit, there's a whole lot of kit that goes along with this. And that's just half of it. Because the technology is improved and because there's lots of other options available now to be able to transport the organs from one area to the transplanting center in a better way, the amount of kit that we take is exponentially growing. Now here's a quick look at the heart. This is what we see when we open the chest. So if you can correlate to the images that we saw before, the heart, if you look at the function, you see the twisting motion, you see the shortening of the fibers, and then overall, the heart looks like it's contracting really well. So the function of this heart is really good. Ultimately, this heart was accepted and it was transplanted in one of the recipient who desperately needed it. Similarly, we've got lungs. These are left and right lungs. That's the hilum. You can see this is the lung. Unfortunately, this video is not playing, but I had a little video of the lungs inflating and deflating inside. Here's some of the lungs that we reject or cannot be used. If you see in the first picture, top left, these are bullae in the apical region. That's the overinflated tissues, lung tissues. This occurs because of smoking, pollution. That's another factor. Here's someone who smokes marijuana or ganja. It damages your lungs severely. We've got at the bottom left-hand corner, that's a cancerous lesion. So even if everything looks all right, Once the surgeon opens up, they visualize and have a thorough check. Now, we've got really experienced surgeons who are very good at finding all these little things. So that's a cancerous lesion. This means that even though the function of the lung is very good, it cannot be utilized for transplantation. We also do within the UK what's called as domino surgery or heart and lung transplant together. Now there's the little heart in the middle, which is still attached to the lungs, and it goes to a person whose both heart and lungs have failed and they need a transplant. So how do we transport? Once we take the organs out of the donor, how do we transport them? So we used to put them in sterile bags, triple bag them. So use 3 different bags to bag them with a layer of 2 liters of normal saline in between each bags so that it's cushioned. Pack that into an ice box and send it through. But now with new technology, this is something that we've been trialing. Our center is one of the key centers that trials out this Paragonix box. So it suspends the heart or the lungs. Currently, it's only the heart into a fluid which retains the temperature precisely between 4 and 5 degrees, which is ideal for the heart to be kept at, so that the metabolic functions within the heart don't keep on going and they don't then destroy the fibers over a prolonged period of time. Because heart, as you know, and as we have ascertained, like Raju Maitreya said, it takes less than an hour for the heart to start, the muscles to start dying off if they have no adequate blood flow. So if they're taken out of the body, you need something to keep them still, and you need to keep them at a lower temperature so the metabolic functions within the cells or within the myocardium are suppressed so that no further damage occurs. And it's 4 hours. If someone's taken the quiz, the maximum time a heart can be left out of the body is 4 hours. It's got to be transplanted within that time. Now, there are newer things that have come out where the heart and lungs can be used, even if they are borderline. So here's something that we used to do. It's called ex vivo lungs. Lungs would be brought back if their borderline function was good. They would put on this little rig where they would pump blood through, they would oxygenate it, they would give lots of medications to get the lung function back. And the other one is called the organ care system. Now, this is you might have seen videos of a human beating heart on a little machine, beating so that the metabolism, the perfusion of the heart keeps on going, keeps it in a very good condition for it to be transplanted within the recipient. Now, here's a little video where we utilize this. We are one of the centers. We are one of the 3 centers within the UK who are responsible for retrieving, putting the heart on the little machine, and keeping the coronaries perfused so that the heart keeps beating, and it's then taken over to the center which transplants them. It's transplanted. The outcomes are quite good as well. But with all these therapies, like we discussed earlier, we have to see if it works effectively. So for all the parents here, I'm sure you know your children will always analyze and assess your performance. This is what actually my son says. My dad performance is going down and down as he gets older. He started correcting me in a lot of things. So that's parenthood for you, something to look forward to for those who don't have children. But we have to, it's very important to make sure that whatever treatment we are giving is working and is working effectively. So let's look at what we do. So these are our 3-year survival statistics after people having an LVAD, the machine. So as Manchester, we stand the highest. In fact, the 2-year analysis we did, our center had the best survival and best complication-free outcomes and survival in the whole of the world. So we stand currently at 93% at 2 years, which is the best in the world. For heart transplants, at 5 years, there's about 67 to 70% who survive and who survive well. So considering that all those patients who are surviving for 3 years, 5 years would have died within a few months if they had not had either the heart transplant or the LVAD. But these are people who've got an extra 3 years or an extra 5 years to live well with their family and try and do what they do. So I say that treatment works. I say it works for majority of them, and it works very well. And if you look at the lungs as well, yes.
Sorry,
Sorry,
just one quick announcement. Is it okay? Sorry to interrupt you.
Yes, go on. Yes.
Okay. The YouTube chat box is on now. So if anybody want to ask any questions, they can freely use the YouTube chat box. And also we have posted the 2 quiz as well as the post-evaluation course links in the YouTube link box.
Oh,
so if you have anybody have any questions, please type your questions at the end of the session. Mr. Shishir or Mr. Raju Maitri, they will answer your questions. Thank you.
Thank you.
Thank you.
Thank you very much. Yeah. I know it was very difficult, and thank you for sorting that out. You and Suresh have been amazing throughout. Thank you so much for that.
Teamwork.
Absolutely. So I'm nearly at the end of my presentation, but again, coming back to the slides, the treatment does work. The therapies offered do work, not 100%, but considering that these people would have died without the therapies that are available, and live well as well, I think it does work. So looking at your outcomes, looking at how efficiently the therapies have worked is also key. It's quite important. Here's something that I found over the years, something which I passionately believe in, which I think is important as well. And if you look at it, from an organ donation point of view, it's one of the, who can argue with the Dalai Lama in terms of spirituality? But he says it's the greatest and the most serious practice of dharma and greatest service to mankind. It is. There are beautiful examples out there, but I found this quite good. And then this one's quite good. This is from Dr. Seuss, one of the books. I don't know if you've read To Your Little Ones, but he puts it quite well. To the world, you may be just one person, but to that one person who gets the organs, you are the world. I've seen a lot of videos where people have donated and their loved ones have gone and met the recipients or gone and met the recording of the heart that beats, in another person, so that there's closure there. This person is alive through someone else. It's a beautiful thing. And organ donation is never a tragedy. It's not, but it's actually a really beautiful thing when someone's passed away. Some part of your loved one lives on. I'm registered to be an organ donor, and it depends. It's an individual choice, but we all say it's a beautiful thing. It's one of the greatest things that you can do. Lastly, coming down to the aspect of end of life. Now we touched on that a little bit earlier, but that is an eventuality which will happen at some point. No therapies can keep anybody going forever. So both VADs and transplants, any kind of therapy, come to an end. So there are certain things that we do when we do know that people come to a life. Now I've got an example. We had one person who would have died straight away. He ended up having an LVAD. He lived on it. And when I say lived, he lived his life. He did what he wanted to do, how he wanted to live his life, and enjoyed a lot of it. Although there are some restrictions that you have to have, but he was able to do a lot of things that he had planned over 6 years, considering that he was going to die within a 2 or 3 month period. He lived on for 6 years, did a lot of things, but we know at the end of that things were getting worse. A lot of complications occurred. So this person came into the hospital on one of our clinics. We did a lot of tests. We found out things weren't going as well, and we had very clear discussions. Now that's one of the things that we do. I feel the team I work with do quite well. We are very open and honest with the way things are. So if things are not working, patients are very grateful when we tell them that, yes, things are not working. You've had a great run. The 6 years of life, which you've not had, unfortunately, has come to an end. Now, these things have happened, which no matter what we do, is not going to improve anything or do anything. So let us talk about it. And the patients then initially, you go through the grief process. You go through all the process where there's anger, where there's frustration, where there's, you go through those phases. But eventually they do come around. They understand it. And then we work together to make them have the remaining time and make the most of it. So what do we do? Palliative care. So that's kind of making the symptoms much more bearable. We try and give them a lot of support from our side, whatever is available. And then eventually, when they go into that phase, now this person had a lot of things done. He wanted to give away his things to his brother, to his family. So he made a will, he wrote down, he physically gave things away. So that was closure for him. And ultimately, one of the last things, and I was there with him when he passed away. So one of the last things he wanted to do was, he said to me, Shishir, I want to sit in a chair and I want to look out the window. So a simple request. And we made him sit out the chair. He was there for half an hour. We laughed and joked. There's no reason you have to be sad because they know that they're passing away and they want to have a good time. They don't want to see our sad faces standing in front of them. So just a normal conversation. So we talked about how good it was, the fun times, the scary times over the last 6 years that he was with our team, under the care of our team, and what he did. Lots of things come out. And eventually, after half an hour, he said, yes, that's it. I'm ready now, he said. And then he stood up, we put him back in bed, and within 5 minutes, he's gone. So, and eventually he said, thank you for this, and thank you for the 6 years you've given us. He thanked the whole team. So more importantly, it was him having that sense of achievement from the last 6 years, that he was able to do things that he wanted to do, which is the key. So that's I think what the aim of treatment should be. So that's what this little quote kind of brings it quite beautifully in the end. It says the purpose of a doctor or any human should not be to simply delay death, but it should be to increase a person's quality of life. Now this is a real person, Hunter Dorothy Adams. He was a doctor. There's a good movie on it. If you ever get a chance, do watch that movie. It's brilliant. It talks about the quality of life of patients, how to talk to a person. Now, this is a distinction he makes. If you look at the sentence again, it says, it should not be to simply delay the death of a patient. So he differentiates the death of a patient to quality of life of a person. So patient and person are two different things. We always see them as patients, as someone who is suffering disease and that. But if you consider them as a person, the whole thing, the whole experience, and the whole approach changes. So look at your patients as a person. You don't have to be paternalistic about it, but they are an individual. They have their own wishes, they have their own quirky needs. Individualism is quite important, so is holism. So I leave you with that, and thank you for being patient. Thank you for your attention. Thank you, sir.
Thank you.
Thank you, Shishir sir. It was very interesting and informative and lucid presentation. I will take your last quote as a message. Not only doctors, but we all nurses or the team members which are involving in the care of the cardiac patient are working for improving the quality of the life, not just increasing the length of the life. Thank you once again, all team of the GINA, and I am handing over this session to the Rajendra sir.
Okay, thank you, sir. Just a few, once again, the gentle reminder, if anybody want to ask the question, please type in the YouTube channel so that we'll be able to pick each questions and we'll be able to answer. And also there's a post evaluation form as well as the 2 quizzes, the link has been posted in the YouTube. So in your own time, you can fill that one. And the post evaluation form, please try to complete in the next within 24 hours to get your certificates. So students who are participated in today's webinar, they can get their certificate directly from us, and they have to go back to their respective principal to get the signature, whereas the nursing staffs, that's optional. Okay, so Mr. Shishir and Mr. Rajiv, we have a few questions here. Just I'm going to read out. If you're able to answer, that will be great, please. One first question is Deepa, and she asked, my mother having a heart problem, like her 2 heart vessels are blocked, which is confirmed by the angiography. The choice of treatment is only surgery, or it can be corrected by the medications.
Rajiv, it's your area of specialty.
Okay.
Yes.
Is it Deepa then, or will I be able to speak to Deepa? Because if there is angiography already showing there is a 2 blockage, she mentioned, and I think she also said the treatment is only surgery, then I think she needs to go with that option because it's been decided by the experts and you can't deny that one. Or, she can take a second opinion from another institution of the cardiology, because we are not an interventionalist here to give the advice on someone's health. And that's the best I can say, unless she want to add something else.
No. That was the right answer. I mean, we understand the disease process, but when the experts have said it, they have said it for a reason. And so, yeah, we'll go with their suggestion.
Any more questions?
Second question by Anupam Das. He has mentioned that how do I know if I have a heart disease? Second question is, what is the hole in the heart? So these are the 2 questions from the Anupam Das.
You want to go, Shishir?
Yeah, sure. Thank you.
Thank you.
How would you know? Now, there's lots of things that precipitate, or the symptoms are different. If you're finding that your exercise tolerance is getting worse, first of all, I would say go and see a doctor. Go and see a cardiologist. Go and see the specialist, because it's not just 1 or 2 things that you need to find out. There's lots of tests to do. It will be very clear from an echocardiography whether you've got a hole in the heart. And hole in the heart has got several meanings. The most common ones are 2. It can either be atrial septal defect or a ventricular septal defect. So we need to find out which one it is and to what extent the defects are, or the hole is. And that can only be checked and actually quantified in a specific way by the cardiologist. So I would suggest, go to the specialist and have a look. There's a huge amount of increase in last decade or so in people self-diagnosing, and because of that, the complications are getting worse and worse, because people either come in too early or come in too late, thinking that I'll be fine, or I've looked into this, but it's not. You don't get all the answers from the internet. There's a specific reason why people have studied this, and there's a specific reason why they become the experts. So seek help out from the experts. It'll save you a lot of hassle and a lot of stress.
And
Thank you, Mr. Shishir.
just to add that is a heart disease is not like a cancer. It is because you will know if you have any problems, you will come to know, and then obviously you will go to the doctors, and then doctors will find out the different investigations, and that's how the diagnosis will be made. Because if you are suffering with the cancer, we don't know until it gives something bad results, and it will spread, and metastasis can happen, and it can get worse. But heart disease is not like that, because if there is a problem, you will experience that, or you will show the one or the other signs of the symptoms. Then you have to go to the experts for the further management.
Thank you, Raji. If any other students or any participants would like to ask the question, please unmute your speakers and ask the questions to the speakers directly, or raise the hands and we'll come back to you.
I think there is someone called Jansi Marian Babu. She was raising the hand before.
Yeah, in the beginning she has raised.
Okay, if she's there, she can ask the question. Yeah. Looks like Huli sir want to say something.
Sir, please can you unmute your speaker, sir? Thank
It's
you,
really
sir.
good. Even our students, many of our students, they also listened. Okay, just now the bell rang, everybody they ran away because today is half day. But all were very nicely, attentively they were listening, and they were asking for certificates. I say, you don't get. I said,
Sir, certificates, we have, we'll post the post-evaluation link in the faculty as well as in principal group, sir, in the WhatsApp group.
oh.
So because of the technical errors today, like there was no chat box was on.
Oh,
So that's why we posted the post-evaluation form in the YouTube link as well as in the, and we are going to post it in the principal as well as faculty group.
send
So
to
once
us.
they'll complete, whoever will complete the post-evaluation form automatically will send the certificates.
Okay, fine. Thank you.
Thank you, sir.
Even last time when we conducted, could not get. I don't know how to. I don't know how could not get. Let's
No, actually, the last sepsis one, actually from our side, it's a delay, sir, because of the hectic lifestyle here. We are so all the certificates of the last session has been posted last night, sir, around 1 o'clock last night.
see.
Yes, sir. So all the certificate has been gone, sir.
I can request there is one request, sir. I can request to all the principals, those who are joined here, they can share the postless link in their teaching means groups. So student can fill the post link forms as we are not added in the flyer.
And at the end of the session, I have few announcements to do. So let this whole session finish. So I'll come back at last.
So just very quickly, can I show something?
Yes, sir.
Okay, sorry, I completely forgot. I bought this little machine from our work. So that's the actual heart rate 3 pump. So if you can look, this is the actual machine. It's roughly the size of a golf ball. So there it is. That sits inside your heart. This little part goes into the left ventricle, pulls blood through and pushes out to the outflow graft that is attached to the ascending aorta. Now, the whole thing sits inside. I don't know if you can see. It's something roughly like that. Everything will be inside. The patient does not feel. It roughly weighs about 700 grams. They don't feel it. Costs about roughly 70 lakhs. The whole surgery costs about, I think about 1 crore. But most importantly, it does make a huge change to the life of people. I've got the paraphernalia, so that's the controller. This will just set some alarm off. Very quickly, I'll show you. That's how it works. And those are the batteries. So the whole thing is about that. This is what they have to carry 24/7 everywhere they go. So that's the sort of cost of quality of life for them to survive. But we've got people who do rock climbing, mountain climbing with these. We've got people who cycle 40, 50 miles 3-4 times a day for weeks and weeks and weeks. Some of them have done mountaineering. They've walked about 10, 15 miles. 7 days. They go to music festivals. They go to camping. They go to different countries. So they do a lot with these. Although it looks quite technical, their life is quite good, actually. So just wanted to show. Thank you.
They shouldn't forget to carry the battery because it has got a battery as well, isn't it? The battery is very important, yeah. Because if they forget to take the battery, then the machine will stop. And Shishir has bought one of the patient who was only disadvantage in his life. He said he was one of the famous singer and guitarist. I think there is some noise coming.
Sorry, it's me. The machine.
Okay. Oh, okay. Yeah, the machine. Yeah. So he was only saying is he used to play the electrical guitar and he couldn't play the electrical guitar, isn't it, Shishir? Yeah. And because it started vibrating, like how the noise was coming, and it was disturbing his full music show. But he changed his lifestyle. You know, he started mountaining and a mountain walk and cycling and things. Yeah, it's really really good. It keeps patients alive by, as it is last statement says, with a quality life.
Yeah. Yeah.
Shishir, Shishir, why is this procedure available in India?
Yes, yeah. There's about 4 or 5 centers who do it. Although the numbers are not too high, but they are doing it.
And is it available in public sector?
No.
In India, so you can't afford it. See, you can't afford this. If it's 70 lakhs, forget it, man. No
It's
one.
about 1 crore.
Yeah.
Procedure is 1 crore.
Yeah.
So that's
Yeah.
that's
There's a version that ISRO is coming up with, which is far cheaper and it's well advanced. It'll come out soon, hopefully after. But if the only problem is the insurance companies have not yet started okaying it. If they
yeah,
do,
of course not.
it should be, because other countries, Germany, Italy, France, not France, but US, they all have this on their insurance. There's a big push in India, but hopefully it'll be there soon. Now our team is involved in training surgeons and teams back home. So hopefully, yeah, that's what we are hoping to see.
Hopefully in the next 5 years.
Oh, I hope so. Yes.
Hopefully. Any more questions?
Sir, Anupam Das has raised the hand in between. He can unmute his mic and he can ask the question.
Good afternoon, sir. Sir, I have one question. What is the heart hole, or what is the causes of heart hole, sir?
Rajiv, do you want to?
Yeah, you can say. No, you can say. Yeah, you already mentioned it before. Yeah.
Anupam, yeah. We mentioned it. I hope if you're talking about someone who you know who's had this, yeah. Our only suggestion would be to take them to a specialist. But heart holes are basically a septal defect. So there's a defect in the septum, either atrial or ventricular. It can only be found out on an echo, which is relatively easy to find. So does that answer your question? Is there anything you would like to know about it?
I think he asked why it is called. It's mostly congenital, isn't it, the cause?
Yes.
Yeah, and it's very common in the children. And when the TOF is when the newborn children are born, it's called tetralogy of Fallot's. And but when the children with the AST or VST, some of the, I think I have seen my nursing colleagues who are living with that. Some people can live with that. The mixture of bloods, and some people need a surgery for that. And then just not one surgery. The surgery needs to be as the age grows. The heart also, the muscle grows, and then obviously the temporary membrane or whatever they put, that doesn't grow. So you need a different kind of membrane and things. So the surgery also need to be repeated. But most of the time, you can just live with the AST or VST.
And it's also quite high in. Is it quite high? Am I right in saying it's quite high in premature babies?
Yes. Yeah. That's right. Yeah.
The foramina ovale does not close. The flap doesn't close up.
Yeah.
Okay. So next question is by Lalita H. Sorry.
What's the question, Lalita?
She has mentioned that her son is 20 years old and he had an MI. So that's and nothing, no more continuation of the question. So Lalita, if you want to unmute your speaker and you can ask the question directly, please. Okay. Okay, we'll come back.
Yeah.
So if any more questions, we can ask. You can ask to speakers directly. Otherwise, we are going to wind up our session now.
Yeah.
Okay. So one more thing, important thing, that we are going to post the Google form link for the registration. So all the nursing, we have the two separate links, one for the students and one for the nursing faculties. So that is the nurses who are working, who are qualified and working in the clinical setting. We have the separate link, and for the nursing students, we have a separate link. So hereafter we have the everyday or weekly education sessions through that links only, not face to face. We may post some YouTube link, or we may post some question and answers. So some kind of the live interaction will be taking place every week. So I request you all complete the registration form and enroll with Global Indian Nursing Associations. Okay, and I hand over to Mr. Suresh for the vote of thanks. Thank you very much. 20, 23rd December.
January.
Sir, 23rd January. Pressure ulcers. Pressure ulcers. Oh, yeah. Identification
Management
of
of
pressure ulcer
pressure
and its
ulcer.
management.
Yeah.
Thank you.
Thank you. And just not to
Thank you.
forget Prabhu Swami, one of colleague from Krishna. He was also very supportive. Thank you, sir. He just there next to Mahesh sir. Prabhu Swami sir is also one of our backbone. Thank you.
I request all the GINA members as well as the Holi sir as well as the faculties from the Krishna College or
Can
the other
stay.
principals to stay back in the faculties, other teaching faculties to stay back in the webinar, please.
Maybe the recording can be stopped now.
Thank you.
Thank you, everyone, for your patience and attention.
Mahesh sir, we can stop the recording maybe.
Yes. Can we conclude the session?
Yes.
Yes, please.
Just for
Oh,
a
yeah.
few minutes,
After
just
that.
only discussion with the principals and teaching
Yeah, yeah.
faculties.
We can conclude the this session and recording.
Okay.
So
thank you.
all students, please can you log out, please?